partially edentulous conditions. To introduce, current practice in the management of partial tooth loss involves consideration of various types of processes, but there is no aspect of dentistry that involves as much variation and individual preferences as designing a removable partial denture. It has been calculated that there are 32,000 different possible combinations of RPD designs. Besides the fact that designing require use of remaining teeth, surrounding tissues, and consequently demand appropriate application of knowledge and critical thinking to ensure the best possible outcome given the patient's need and desire. It has been based more on what they feel comfortable. Designing the RPD framework should be done with a great care considering the biomechanical principles of RPD construction and must be neatly drawn and positioned on the accurate diagnostic cast because the complete design will serve as a blueprint for the laboratory person responsible for RPD construction. Various authors propose classification of partially edentulous arches. The most widely used classification was proposed by Dr. Edward Kennedy of New York in 1925. He divided edentulous arches into 4 categories, with class 1 being most common and class 4 being least common. So, Kennedy's class 1 is characterized by bilateral edentulous areas located posterior to the remaining natural teeth. Class 2 displays a unilateral edentulous area located posterior to the remaining natural teeth. Class 3 presents a unilateral edentulous area with natural teeth both anterior and posterior to it. Class 4 displays a single bilateral edentulous area located anterior to the remaining natural teeth. It is important to note that the edentulous space must cross the dental midline. Coming to the basic principles of RPD design proposed by Dr. E.H. Smith, according to him, following 5 principles should be considered during the fabrication of RPD. First, the dentist must have a thorough knowledge of both the mechanical and biological factors involved in RPD design. The dentist must know about the various forces acting on the denture and soft tissues and their response to these forces. Second, the treatment plan must be based on complete examination and diagnosis of the individual patient. Any negligence in the appropriate diagnosis will lead to a failure of the prosthesis. Third, the dentist must correlate the pertinent factors and determine a proper plan of the treatment. The dentist must examine the existing oral conditions and do the necessary modification before designing a RPD. Fourth, a removable partial denture should restore form and function without injury to the remaining oral structures. It should produce adequate aesthetics and function without compromising on the health of the soft tissues. Fifth, a removable partial denture is a form of treatment, not a cure. Even after insertion, the patient should be recalled and reviewed to ensure success of the treatment. Common observation clearly indicates that the ability of living things to tolerate force is largely dependent upon the magnitude and intensity of the force. Consideration of forces inherent in the oral cavity is critical. This includes the direction, duration, and magnitude of the forces applied to the abutment teeth and the residual ridges. If the potentially destructive forces can be minimized, then the physiological tolerance of the supporting structures are not exceeded and pathological changes do not occur. The force forces occurring with RBD function can be widely distributed and directed, and their effect can be minimized by appropriate design of the RBD. An appropriate design includes the selection and location of components in conjunction with a harmonious occlusion. An understanding to simple mechanics applied to the design of the RBD can help to accomplish the objectives of the preservation of oral structures. In designing RBD, consideration should be given to avoid lever and inclined planes. The direct retainers and the minor connectors slide along the guide planes of the teeth and can act as inclined planes if not prepared correctly. When a force is applied against an inclined plane, it may produce two actions. One, deflection of the object which is applying the force. Second, movement of the inclined plane itself. These results should be prevented to avoid damage to the abutment teeth. Lever in its simplest form is a rigid bar, supported somewhere along its length. It may rest on the support or may be supported from above. The support point of the lever is called fulcrum, and the lever can move around fulcrum. There are three types of lever. Each lever modifies the intensity of the force acting on the denture to a different degree. In first-class lever, the fulcrum is in the center, resistance at one end, and effort at the other end. These levers are more easily controlled, usually seen in the distal extension RBDs. In second-order lever, fulcrum is at one end, effort at the opposite end, and resistance in the center. This type of lever action is seen as indirect retention in a removable partial denture. In third order lever, fulcrum is at one end, resistance is at opposite end, and the effort is at center. This type of lever doesn't occur in removable partial denture. The length of the lever from fulcrum to resistance is considered as resistance arm, and from fulcrum to the effort is considered as effort arm. Whenever the effort arm is longer than the resistance arm, mechanical advantage is in favor of effort arm, proportional to the differences in the length of two arms. When resistance arm is lengthened, the effort arm is more efficiently counteracted. Denture bases of distal extension RBD can rotate in relation to three cranial planes when forces are directed on it. One is the rotation around a fulcrum line passing through the most posterior abutments when the denture basis moves vertically towards or away from the supporting alveolar ridges. Second rotation can occur around longitudinal axis formed by crest of the residual ridges. Third, rotation can also occur around the vertical axis located near the center of the arch. This occurs due to differences in supporting characteristics of abutment teeth and soft tissue covering the residual ridge. Even though the actual movement of the denture bases may be small, a lever force may pose detrimental effects on abutment teeth. Cantilever design for distal extension cases should be avoided, and alternative designs to minimize the destructive potential should be used. A tooth is apparently better able to tolerate vertically directed forces than non-vertical torquing or horizontal forces because more periodontal fibers are activated to resist the application of vertical forces to teeth than are activated to resist the application of non-vertical forces. An abutment tooth will better tolerate non-vertical forces if these forces are applied as near as possible to the horizontal axis of rotation. Coming to various factors influencing design of RBD. First, arch relationship, which includes occlusal relationship of remaining teeth, orientation of occlusal plane, space available for restoration of missing teeth, arch integrity, and tooth morphology. Second, the type of major connector indicated is always based on existing and correctable oral situations. Third, if distal extension bases are involved, need for the indirect retention, clasp design that will minimize forces directed towards abutment teeth, and the type of base material for later rebasing should be considered. Fourth, materials to be used for framework and bases can influence RBD design. Fifth, type of replacement teeth to be used is always influenced by the opposing dentation. Need for abutment restoration may influence the type of clasp arms to be used. Patients' past experience and reason for making a new denture can also influence the design. Response of oral structures to previous stress and the amount of abutment support remaining. Also, the method of replacement of teeth can also influence the RBD design. Essentials of partial denture design. Design of the partial denture framework should be systematically developed and outlined on an accurate diagnostic cast. To develop the design, the first step is to determine how the partial denture is to be supported. In an entirely tooth-supported partial denture, the most ideal location for the support unit is on prepared rest seat on the occlusal cingulum or incisal surfaces of the abutment adjacent to each edentulous space. The type of rest and amount of support required must be based on interpretation of the diagnostic data collected from the patient. In evaluating the potential support an abutment tooth can provide, consideration should be given to periodontal health, crown and root morphologies, crown to root ratio, bone index area, location of the tooth in the arch, relationship of the tooth to other support units, and opposing dentation. In a tooth and tissue supported partial denture, attention to these same considerations must be given to the abutment teeth. However, equitable support must come from the edentulous ridge areas. In evaluating the potential support available from the edentulous ridge areas, consideration must be given to the quality of the residual ridge, which includes contour, quality of the supporting bone, and quality of the supporting mucosa. The extent to which the residual ridge will be covered by the denture base, the type and accuracy of the impression registration, the accuracy of the denture base, the design characteristics of the component parts of the partial denture framework, and the anticipated occlusal load. Denture base areas adjacent to abutment teeth are primarily tooth supported. As you proceed away from the abutment teeth, they become more tissue supported. Therefore, it is necessary to incorporate characteristics in the partial denture design that will distribute the functional load equitably between the abutment teeth and the supporting tissues of the edentulous ridge. Locating tooth support units on the principal abutment teeth and designing the minor connectors which are adjacent to the edentulous areas to contact guiding planes in such a manner that they disperse the functional load equitably between the available tooth and tissue supporting units will provide design with a controlled distribution of support. designing and locating major and minor connectors in compliance with the basic principles and concepts. The major connector must be rigid so that forces applied to any portion of the denture can be effectively distributed to the supporting structures. Minor connectors arising from the major connector should transfer functional stress to each abutment tooth through its connection to the corresponding rest. Now, the third step is to determine how the removable partial denture is to be retained. The retention must be sufficient to resist reasonable dislodging forces. Retention is accomplished by mechanical retaining elements, that is clasp, being placed on the abutment teeth and by intimate relationship of the denture bases and major connectors with the underlying tissue. The key to select a successful clasp design for any given situation is to choose one that will avoid direct transmission of tipping or torquing forces to the abutment, accommodate the basic principles of clasp design by definitive location of component parts correctly positioned on the abutment tooth surfaces, provide retention against reasonable dislodging forces with consideration for indirect retention, and be compatible with undercut location, tissue contour and aesthetic desire of the patient. Location of the undercut is the most important single factor in selecting a clasp. The fourth step is to connect the retention units to the support units. If the direct and indirect retainers are to function as designed, each must be rigidly attached to the major connector. The fifth and the last step in this systematic approach to design is to outline and join the edentulous areas to the already established design components. Coming to the factors which influence the magnitude of the stress transmitted to the abutment tooth. First is the length of edentulous span. The longer the edentulous span, the longer will be the denture base and the greater will be the force transmitted to the abutment tooth. Second is the quality of support of the ridge. Large well-formed ridges are capable of absorbing greater amounts of stress than small, thin or knife-edge ridges. Broad ridges with parallel sides permit the use of longer flanges on the denture base, which helps to stabilize the denture base against the lateral forces. Third is the type of mucosal covering. A mucoperiosteum, which is approximately 1 mm thick, gives good support compared to a thin atrophic mucosa. Next is occlusal relationship of the remaining teeth. Improper occlusal relationship and a steep occlusal plane tend to increase the amount of force acting on the denture. Poor occlusal relationship can lead to supraeruption of the opposing natural teeth. Next is the type of clasp. A flexible retentive clasp arm decreases the stress that will be transmitted to the abutment tooth, but it provides less horizontal stability. Next is the design of clasp. A clasp should be passive when it is completely seated on an abutment tooth. The passive clasp will exert less stresses on the tooth. Next is amount of clasp surface in contact with the tooth. A clasp should be designed so that the reciprocal arm contacts the tooth before the retentive tip passes over the greatest bulge of the tooth during insertion. And it should be the last component to lose tooth contact during removal of the prosthesis. Next is construction of clasp. Doubling the length increases the flexibility by 5 times. This decreases the stress on the abutment tooth. Using a curved rather than a straight clasp on an abutment tooth will aid to increase the clasp length. Next is material used in clasp construction. A clasp constructed of chrome alloy will exert more stress on the abutment tooth than a gold clasp because of its greater rigidity. To decrease the stress, the chrome alloy clasps are constructed with a smaller diameter. Next is the abutment tooth surface. The surface of a gold crown or restoration will offer more functional resistance to the movement of a clasp arm than enamel. Therefore, more stress is exerted on the tooth restored with gold than on the tooth with intact enamel. Next is the areas of the base to which load is applied. The occlusal load should be applied on the center of the denture bearing area both antero-posteriorly and buccolingually. So coming to the design consideration in control of stress. First is retention. Denture should be designed in such a way that the retention obtained from the clasp is just enough to provide adequate retention to prevent dislodgement of the denture. Retentive clasp should be designed such that it is active only during the insertion and removal. Forces of adhesion and cohesion can be increased by recording an accurate impression so that the denture base fits accurately to the supporting tissues, and also by increasing the denture bearing area, which in turn increases the retention of RPD. Atmospheric pressure may also contribute to retention. Generally, major connectors are beaded at their margins so that a tight wall seal is obtained. Preparation of guide planes on the proximal surfaces of teeth adjacent to edentulous spaces increases the retention by frictional contact. The action of lips, cheeks, and tongue can be a major factor in the retention of the denture. Properly contoured denture base can aid to improve the patient's neuromuscular control of the prosthesis. An overextended denture will get constantly displaced due to the neuromuscular action. Frequent displacement of these denture will lead to excessive stress on the abutment. Second is the clasp positioning. Lever forces can be controlled entirely by means of clasp if there are sufficient abutment teeth present. Quadrilateral configuration is the most efficient in controlling the stress developed within a denture. This design involves the use of 4 clasps. It is used commonly for Kennedy's class 3 arches, particularly when there is a modification space on the opposite side of the arch. Tripodal configuration involves the use of 3 clasps. Other factors for control of stress includes clasp design. Flexible clasp produces the least stress and the rigid cast circumferential clasp produces the maximum stress on the abutment. Indirect retention is produced by moving the axis of rotation of the denture away from the point of application of force. Denture base. The denture base should be designed to cover the maximum amount of soft tissue available. The denture base should have a long flange in order to stabilize the denture against the horizontal movement. The distal extension denture bases must always extend onto the retromolar pad area in the mandible and cover the entire tuberosity in the maxilla. A functional impression should be recorded to fabricate the denture in order to improve its adaptation and avoid excessive tissue displacement. Coming to the differences between class 3 and other types of RPD conditions. First is the manner of support. The Kennedy's class 3 RPD is entirely tooth supported. Secondly, It doesn't require an impression of the functional form of the ridge tissues. It also doesn't require indirect retention. Cast class of either circumferential design, bar type, or combination class may be used depending on how one can modify surfaces of the abutment teeth. Denture-based materials that can be relined are used in situations like recently extracted teeth, but bases made up of metal are recommended usually. Components of Class 3 Removable Partial Denture Design. First, direct retainer. As prostheses are entirely tooth-borne, the transmission of harmful forces to the abutment and ridges can be minimized. The position of the retentive undercuts are not critical. Clasp. Quadrilateral positioning is considered ideal. 4 clasps should be placed to obtain a quadrilateral design. Tooth and soft tissue contours, aesthetics should be considered, and reciprocal elements of the clasp must be rigid. Rest. It should be positioned adjacent to the edentulous space and should support major connector and the lingual plate. Indirect retention is usually not required. Major and minor connector must be rigid and should not impinge on the gingival tissues. Usually, a palatal strap is used, but if the modification spaces are present, antero-posterior bar can be considered as option for major connector. Minor connectors should be positioned to enhance comfort, cleanliness, and placement of artificial teeth. Occlusion. Maximum intercuspation should coincide centric relation. Harmonious occlusion should be established. Prosthetic teeth should be selected and placed to minimize stresses on the prosthesis. Denture bases. Functional impressions are not required. Coverage of the residual ridge should be determined by appearance, comfort, and avoidance of food infection. Components of Class 4 Removable Partial Denture Design. Fixed partial dentures are contraindicated in situations like where the ridge resorption may necessitate the addition of an anterior flange, where the condition of abutments may not be suitable for bridge support, or the conditions where the length of the edentulous span may put more strain on the abutments. So, in such cases, removable partial dentures are advised. Movement of removable partial denture for Kennedy's Class 4 arches and the stress transmitted are different from those seen in the other classes. Aesthetics and phonetics requirement may place teeth anterior to the crest of the ridge, resulting in the tipping and rotational forces to the abutment. So, these stresses can be minimized by preserving the hard and soft tissue components of the anterior edentulous ridge. A central incisor or other tooth can be retained to serve as an intermediate or an overdenture abutment which minimizes the rotation, because shorter the edentulous area, the lesser are the tipping forces. A quadrilateral configuration of direct retainer is considered ideal. Rest should be located immediately adjacent to the edentulous area anteriorly and should be present on posterior teeth to maintain quadrilateral configuration. Clasp. Posterior embrasure clasp are recommended, and anteriorly clasp can be given directed from distal surface of the abutment tooth to terminate mesially. Connector. The major connector should be rigid. Horseshoe shape major connector can be utilized. In case of increased rigidity is required, antero-posterior bar can be considered as an option. Indirect retention should be located posterior to the fulcrum line. Functional impressions may be indicated if the edentulous area is large. Newton and Quinn in 1989 described a technique in which acrylic resin extensions from the labial surfaces of the anterior tissue base of Kennedy's Class 4 RPT are used as retentive elements to minimize motion around the axis of rotation. The labial rests formed by extending the base material act as guiding planes and also improve aesthetics by covering the interdental spaces. Additional considerations influencing design. First is the use of a splint bar for denture support. Occasionally, a situation is found in which it is necessary that several missing anterior teeth to be replaced with the RPD rather than by a fixed restorations. In such situations, it is necessary to provide the best possible support for replaced anterior teeth. Usually, this is done through the placement of occlusal or lingual rest or both on the adjacent natural teeth. But when the edentulous span is too large to ensure adequate support from the adjacent teeth, the other methods must be used. An anterior splint bar may be attached to the adjacent abutment teeth in such a manner that splinting of the abutment teeth results with a smooth, contoured bar resting lightly on the gingival tissues to support the RPT. Regardless of the type of retainer used, the connecting bar may be cast of a rigid alloy or commercially available bar may be cast to the abutments or attached by soldering. The length of the edentulous span influences the size of the splint bar. Long span require more rigid bars than the shorter spans. Chromium cobalt alloys are usually recommended for casting of the splint bar because of their great rigidity. The splint bar must be positioned antero-posteriorly, just lingual to the residual ridge to allow an aesthetic arrangement of artificial teeth. This type of RPT will have aesthetic advantages of removable anterior replacements and positive support, retention and stability from underlying splint bar. Second is the internal clip attachment. The internal clip attachment differs from the splint bar in that it provides both retention and support from the connecting bar. Several preformed connecting bars are commercially available in plastic patterns which can be customized for length and cast in the metal alloy of choice. They are also available in various metal alloys and durable nylon. The internal clip attachment provides support, stability and retention for the anterior RPD and may serve to eliminate both occlusal rest and retentive glass on the adjacent abutment teeth. To summarize, retention should not be the prime objective of the design. Instead, efficiency, aesthetics, patient's comfort and preservation of remaining oral structures must be taken care of. Simplest type of clasp and connector that will accomplish design objective should be employed. Tooth support should be exploited to the extent that it is available. No parts of the RPD framework should impinge on the free gingival margin. All connectors must be rigid. Principles of indirect retention should be employed whenever possible. Harmonious occlusion should be developed and the base of the removable partial denture should be constructed from a functional impression. So, to conclude, it is important while designing the RPD framework that the basic principles of designing are not violated. Choice of retainer, placement of rest, connector design, all are critical factors. However, the fact remains that the adequate time must be spent in proper diagnosis and devising a workable treatment plan in terms of patient's prosthetic needs and expectations. Once this is achieved, the mechanical task of laying out the nuts and bolts of RPD design can be carried out to ensure that our patients receive the full benefit of our knowledge and